been asked to talk about indications and contraindications of unicondylar knee arthroplasty. So, UKR, like TKR, has undergone its own share of transformation to the very rudimentary implants to the present state-of-the-art implants and techniques that we have. Osteoarthritis of knee is a progressive disease, and a lot of classifications take into account that very thing, from just involvement of the medial condyle in the very early stages of reduction of joint space to complete augmentation and involvement of all three compartments. So X-ray would look like this for a grade 1, which is a reduction of the joint space, but there's still not bone on bone. To stage 2, where it's bone on bone, but the ACL is still intact and the MCL is still not contracted. To an advanced stage where even the bone gets attritioned. So when we talk of a unicompartmental knee replacement, what we are looking for is involvement of the medial tibiofemoral condyles with bone-on-bone arthrosis, but with intact ACL, functionally intact ACL, and non-contracted MCL. So this is what is the concept of an anteromedial osteoarthrosis. Basically, anteromedial osteoarthrosis means that only the anterior or perhaps the middle third of the tibial condyle is involved. The reason being that ACL, functional ACL, keeps the tibia in weight-bearing position in the anterior half. As the ACL is going to become increasingly dysfunctional, the wear starts occurring posterior because of the unopposed action of the PCL. So, which means that an intermedial OA knee would correct in valgus stress with an intact lateral compartment, showing that the lateral cartilage is still intact. So these are some of the typical examples. As the ACL becomes increasingly dysfunctional, the wear starts moving more and more posteriorly. And as the posterior wear becomes more and more, the ability of the knee to correct is also lost. Plus, on stress, you will find that there is collapse of the lateral compartment as well. That is what is basically stage 3 osteoarthritis. So again, indications remain the anteromedial OA with an intact ACL, functionally intact ACL. There may be striations up to 50%. Loss of ACL substance is acceptable, but it should be functionally intact. And full thickness lateral cartilage with correctable varus and flexion deformity less than 15 degrees. With UKR, it's very difficult to correct flexion deformity. So whatever flexion deformity is there will remain, and it will stretch out gradually over a period of time. And 15 degrees possibly the limit beyond which it's not possible to, for that deformity to correct. So some of the contraindications which were there earlier are no longer considered. Patellofemoral joint is relative. Perhaps lateral involvement of the patellar facet is an absolute contraindication, but also probably a symptomatic patellofemoral involvement where the patient complains of pain while descending the stairs or sitting up or getting up from the sitting position is perhaps a relative contraindication. Obesity, age, and activity also are no longer considered contraindications, but over a period of time they have been, better defined in the sense that obesity and age are now relative contraindications, in the sense that if you are doing a fixed bearing, probably BMI more than 30 degree might not be that conducive to a long-term good result, but age is definitely not a contraindication. So we've already, so Inflammatory arthritis is an absolute contraindication. You're not going to perform this surgery if there's even a suspect of inflammatory arthritis in the joint. Similarly, previous HTO is contraindication. The dynamics of a previous HTO, failed HTO, the dynamics are disturbed, and it's probably not a good idea to sort of treat that knee with a unicompartmental knee. So age, again, old, unfit is an ideal patient, but we tend to define unicompartmental for young patients, but old patient would probably have this as a final surgery because of low morbidity associated with a unicompartmental is probably ideal for some of these patients. Again, obesity is not a contraindication, but for females, especially females, short females like we tend to see in our practice, some of these patients have a very large and a very prominent ulcer on the lateral femoral condyle, and it's right in the weight-bearing area. So probably if you're doing it for a obese patient, it's better to have a good look at the femoral condyle and not just rely on the valgus stress X-ray. So to summarize, the ideal candidate for uni would be a bone-on-bone arthrosis, probably grade 2, male or female, low activity level, preferably an elderly patient, but age no bar, non-obese and non-symptomatic petrofemoral involvement with no instability or contracture, flexion contracture less than 15 degrees, and a correctable deformity. So if you keep these things in mind, it's not difficult to get an excellent result and to achieve a very satisfactory outcome for patient as well as a surgeon. Thank you.